we're each going to do is I'm Melinda Irwin, and I'll present myself in a second, and I'm going to present an overview of what we know in regards to weight and cancer prevention. And then Dr. Boyd is going to drill down and mention a bit more about nutrition and cancer. And then Dr. Freedman will present exercise and the research for lowering risk of cancer and or also once diagnosed with cancer. So I am delighted to join Dr. Barry Boyd and Janet Friedman, and I'd like to introduce them. Dr. Boyd is a practicing medical oncologist since 1993. He founded the integrative medicine program at Greenwich Hospital, Yale Health Systems in 1998. He's an assistant clinical professor of medicine at Yale School of Medicine and a senior oncologist at the Yale Smilow Care Center in Greenwich. He's also the director, he also was the director of curriculum and nutrition and the director of curriculum of integrative medicine at Yale School of Medicine from 2008 to 2012. He's a leader in the field of integrative cancer care with a targeted focus on nutritional support for cancer patients, incorporating emergent evidence-based medical oncology with cancer-specific nutrition counseling. He combines comprehensive support for the healing process. He is a founding president of the Integrative Cancer Care Research Foundation and a board member of Environment and Human Health, which is a nonprofit organization made up of physicians and public health professionals dedicated to the purpose of protecting health from environmental harms. And on a personal note, I've so enjoyed interacting and collaborating, and hope we collaborate more with Dr. Boyd over the past 20 years. He really knows his stuff in regards to nutrition and cancer. So look forward to his talk in a couple minutes. And then Dr. Janet Friedman, who I'm delighted to meet this evening, is a physiologist in practice at Greenwich Hospital. She received her MD from the University of Wisconsin and did her specialty training in physical medicine and rehabilitation at NYU Rusk Institute. She's also trained in medical acupuncture at UCLA and incorporates acupuncture into her practice. And prior to coming to Connecticut, she was an attending and medical director of the Department of Rehabilitative Medicine at Bellevue Hospital in New York City. And she's going to give a fantastic talk on exercise and cancer. And to start us off, I'm going to open up my slides and I'm going to give an overview of this topic of lifestyle behaviors in cancer. And I am a professor of epidemiology at the Yale School of Public Health and an associate cancer center director at the Yale Cancer Center. I've been at Yale for about 20 years now, studying the role of lifestyle factors in cancer prevention and control. And I'm excited to share with you some of the studies we've done over the past 20 years, as well as some studies that are in progress that we're currently recruiting patients to. So give me a second as I pull up my slides. And also for all the attendees, I encourage you to use the chat box to type in your questions. We are going to answer all of them at the end. However, I and Dr. Boyd might answer some of them after our talks, and so look at the chat box. Okay, so let me just share my screen. And the hardest part is always finding your slides. Okay. Okay, can you see that? Good, can you see that? Let me just see that.
It's not in presentation mode.
Okay, give me one quick sec, because this always happens. I have two monitors, and I'm going to present slider view. Is that good?
Perfect.
Okay, great. Okay, so the role of lifestyle behaviors in cancer prevention and control. So excitingly, since we've had a large decrease in cancer mortality rates, about a 30% decrease since the peak in the 1990s. And you can see that this decrease is among men and women. And that this 30% decrease over the past 2 or so decades was due to 3 primary factors. One, improvement in detecting cancer, which means an earlier onset of an earlier stage at diagnosis, a significant improvement in cancer treatments, immunotherapy, and a number of other targeted therapies have significantly improved survival rates. But number three, a lifestyle factor that was critical in reducing cancer mortality rates, and that is tobacco control. So tonight we're going to focus our talk on lifestyle behaviors of nutrition and physical activity, but there's much we can learn from the policy and other sort of changes in standard of care that occurred with tobacco control. So why do we want to study lifestyle behaviors in cancer? Well, as I just mentioned, this 29% drop in mortality rate since the peak in 1991 is really exciting. However, will this decline in cancer mortality rates be offset by the rise we're seeing in obesity, as well as poor diet and sedentary lifestyle? Much of this due to our built environment and not a personal choice, but more to the changes in technological advances that make us very sedentary, changes in the food environment. Walking into a grocery store is vastly different today than it was 10, 20, 30 years ago. Unfortunately, 40% of adults are obese, which is defined as a BMI of 30 or greater, and this is a six-fold increase in obesity rates since the 1970s. We know that 18% of cancer incidence and 16% of cancer mortality is attributable to excess weight, poor diet, and physical inactivity, and that there are 14 cancers associated with obesity and 13 cancers associated with low physical activity levels. The good news is that among those with cancer, there's been a growing number of studies showing that exercise and weight management or prevention of weight gain or weight loss favorably impacts surgical outcomes, treatment efficacy, treatment side effects, and disease-free survival. So this was a really interesting paper that was published in the Journal of the American Medical Association about almost 3 years ago now, that looked at all-cause mortality. So not just cancer mortality, but all-cause. And this was really drilling down to the root causes. So when you ask people what are the causes of mortality, they will probably say cardiovascular disease and cancer, and that is true. But if we take a step or go even more upstream as to what causes cancer and cardiovascular disease, and that's what this paper did, the number one factor is diet. And that explains over 500,000 deaths per year is a poor diet. And you can see the other factors are high BMI and low physical activity. It's important to note tobacco use here is right below diet. And then some of the other cardiovascular endpoints, blood pressure, glucose, cholesterol as well. But it's important to note that these modifiable lifestyle factors are our root causes of much of our all-cause mortality. So I mentioned that there are 14 different types of cancer associated with a high BMI, and you can see in this figure the different cancers. Much of the research, including my own, has focused on breast cancer and ovarian cancer, but there's the highest risk actually is with endometrial cancer. And then there's a number of other cancers here, some that are being studied more in detail, colorectal, of course, but others understudied, such as multiple myeloma. Liver cancer is a lot of research focused on that right now as well as pancreatic. So these are the guidelines. So the dietary guidelines, actually, there are new ones that just came out. They're hot off the press as of about 2 weeks ago. So if you Google the dietary guidelines for 2021, they'll come out, but they're very similar here. And what you'll note, it's not about a particular nutrient, but it's more about our healthy eating pattern and to focus on nutrient density and, most importantly, limiting our calories from added sugars. And thankfully, the food label was recently changed. The FDA requires now that on the food labels, there is a line that shows added sugars. That to me, and Dr. Boyd may disagree or agree, that to me is the number one most important factor to look at is the added sugars on the food label. And then, shifting to healthier foods and beverage choices. And then for physical activity, the take-home message here is about 2.5 hours per week of exercise. Some think of that as about 30 minutes a day of brisk walking or a moderate intensity exercise. However, there's been some really exciting research out of Harvard showing the weekend warrior, the person who does the 2 to 3 hour hike or snowshoeing or walking on the weekend, that lowers your risk of developing or dying of cancer, similar to if you do some every day. So briefly, what are the mechanisms? People always think, well, wait, how can maintaining my weight or exercising or eating healthy lower my risk of developing or dying of cancer? So this is in regards to breast cancer, but it's this similar mechanisms for a number of the cancers. And there's 3 mechanisms. Estrogen seems to be a major driver, so much so that in breast cancer, we know that a standard of care treatment is after diagnosed with an estrogen receptor positive breast cancer, women will be recommended to take tamoxifen or an aromatase inhibitor. That blocks estrogen either locally or systemically throughout the body. So can exercise and nutrition and weight management lower estrogen? Yes, there's evidence of that. Another major mechanism is insulin and also inflammation. And we can measure all of these markers in the blood to see how adding exercise to your daily routine or changing your diet or maintaining, losing, or preventing weight impacts these markers that are strongly associated with cancer. And so that is a study that I was fortunate to work on out of the Fred Hutchinson Cancer Research Center. This is what's called a four-arm randomized trial where over 400 women were randomized to either a diet intervention, an exercise intervention, or the combination of diet and exercise. And then the 4th group was a usual care group. At baseline, none of them were following the dietary guidelines nor exercising at recommended levels. So they definitely had room for improvement. And what we found, this was a year-long trial, and all the takeaway message here is simply to see, look at all those negative signs and those large percentages. If you look at this last column here, you see a 24% decrease in insulin levels simply with changing your diet and exercise. And the weight loss goal was 10%, but actually the average weight loss in this trial was about 5% weight loss. So you can see that exercise and diet associated with about a 5% weight loss leads to these significant clinically meaningful decreases in these biomarkers. CRP, C-reactive protein, is a marker of chronic inflammation, strongly associated with obesity and strongly associated with cancer. And you see a 41% decrease with just a modest intervention of healthy eating and exercise. So here at Yale, over the last 5 or so years, we've done a similar study in women with breast cancer. So once diagnosed with breast cancer, if you change your diet and you exercise and you have about a 6% weight loss, which is what we observed here. This was a 6-month-long trial with a 6% weight loss occurred. This was a telephone counseling group versus in-person, similar weight loss with both groups. And that led to about a 30% decrease in C-reactive protein, a major marker of inflammation, and also about a 10% decrease in insulin and about a 15% decrease in leptin. So I hope these findings are encouraging to you that preventing weight gain or trying to do a little bit of exercise every day can lead to, and following a healthy dietary pattern can have large impact on your cancer risk and mortality. So quickly, I want to shift to talking about treatment adherence. So this was an observational study published about 5 years ago. And I know it's hard to read. It's different cancers: breast, ovarian, lung cancer, colorectal. And these bars are the percent adhering to the chemotherapy protocol. That you would want this to be 100%, that the regimen you're prescribed for chemotherapy at the outset, every patient adheres to it 100%. But in fact, patients don't because of side effects, because of toxicity. And that's called the relative dose intensity. So you can either have a dose reduction in the amount of chemo given or a dose delay. Maybe you wait a week or 2. And what this observational, very large study found is that a reduced chemotherapy completion rate was more common in older patients and in those with obesity and low physical activity. So this was observational, and we wanted to see if this is similar in our patient population. So this was an analysis led by Tara Samt, who's a breast oncologist at Yale, and her medical student, Alana Uziskin, that did a chart review of about 200 women who received neoadjuvant chemotherapy at Smilow. And what we found, I'll just get down to the snapshot here, is that 56%, about half, had a reduced RDI. So about 50% are not completing their chemotherapy regimen because of side effects. And that patients with a pathologic complete response, which means a really good response, the chemo was effective in reducing the breast cancer, had a lower BMI, and that exercisers were more likely to complete chemotherapy than non-exercisers. Once again, observational findings, but implying that there are associations between our behaviors and cancer outcomes. So Dr. Samt and I are now leading a trial funded by the National Cancer Institute, and this is still open. We're still accruing about 20 more women from Greenwich and from the other Smilow care centers across the state of Connecticut, specifically to women recently diagnosed with breast cancer who will be beginning chemotherapy, to randomize them to our intervention or referral to the Survivorship Clinic, which is 2 sessions, versus the lean intervention, which is 16 sessions over 1 year. And we're going to look at a number of these outcomes associated with cancer. So if you're interested, please send me an email. And this is just a snapshot of a lot of the material we use in our intervention to increase exercise and healthy eating habits. So I'm going to close too with the biggest and most important takeaway is at Greenwich Hospital and at Yale, we have a survivorship clinic where patients can come and can get counseling for nutrition, exercise, see a social worker, get an end of treatment summary plan. And I really encourage patients to reach out to their hospital and make an appointment with their survivorship clinic. And in closing, my goal, and I believe Dr. Boyd and Dr. Freedman would agree, is that we really hope that the research findings change clinical practice so that, you know, if and when diagnosed with cancer and you see the surgeon and the oncologist, you also see the dietitian and the physical therapist or the exercise trainer to help with these lifestyle behaviors at the outset of a diagnosis. So I thank you for your attention, and I'm now going to turn it over to Dr. Boyd. So I'm going to encourage you all to type in the chat if you have any questions, and while Dr. Boyd pulls up his slides.
So everybody, does everybody see this?
No.
Just as I was afraid.
If you can't you could email it to me and I can try to pull it up, but are you able to share the screen and see your files right now?
Let me just see. Let me go back. Let me go out.
No. Should we see if Dr. Friedman wants to go now? If you want to try to pull up your slides, and then Barry, if you want to email me yours.
Yeah, sure, then I'll email.
All right, hopefully I'll have more luck. Oh, maybe not either, huh?
Yep.
There we go. That's all the way at the back. Something happened, so you get a little view. Okay. All right. So I'm going to speak about exercise, and to talk about exercise, we have to talk about muscle. And muscle is the largest organ in the body, and we think of it predominantly as what we use for locomotion, what we use for lifting things, and it helps us with breathing. And the word muscle comes from the Latin musculus, which really means little mouse. And this is the arm, this is the biceps. And the early anatomists felt that when we flex and we make our biceps bulge, it looked like a little mouse running under the carpet. So we know what their anatomy labs looked like in those days. But muscle is also what's called a secretory organ. So while we may think of organs as the heart and the lungs and the pancreas, muscle is an organ also. And it produces and releases proteins, just like many other organs in our body, that serve a purpose in another part of the body. So our muscle has a purpose that has nothing to do with locomotion or movement or lifting things or working in life. It also makes chemicals, proteins, that then travel through the body and have an effect in other places. And we make these as the result of muscle contraction, as the result of using and moving our muscles. And these substances then interact with adipose tissue, the liver, the bone, the pancreas. As you just heard, these are things that greatly reduce inflammation in the body and insulin resistance in the body. So our muscles are like our natural anti-inflammatory medicine. And that is how they're responsible for a lot of the health impact of exercise. So a very recent study published in Circulation, this is part of the Framingham study. And Framingham, Massachusetts has been for decades a public health study in which the people of Framingham keep track of every factor of their life, what they eat, their exercise, smoking, drinking, their work, etc. And then that is looked at in regards to their health. So they took 1,200 people and put them on a bicycle for 12 minutes, and they vigorously bicycled for 12 minutes. And they tested 588 different features in their blood, different metabolites. And 80% of those changed their levels after only 12 minutes of exercise. This happened in all ages of people. It was a little less pronounced in people with higher body weight, but it did change in everyone. And very importantly, some of the metabolites associated with insulin resistance, inflammation, etc., dropped. So this was a interesting beginning study to try to see, as we heard, we have different ideas of how much exercise do we need to do to get the benefits, and that these short spurts of vigorous exercise may actually be helpful as well. So as we also heard, exercise can reduce the occurrence and the recurrence of many cancers. And I'm just going to run through a few studies that highlight this. So this is part of the nurses study, another study of thousands of women around the country that has been going on for decades, where nurses who are, at the time that this study began, were mostly women. There's a doctor study because doctors were then mostly men. But here, 3,000 women roughly with stage 1 to stage 3 breast cancer in the study, and they're really followed through their lifetime. And the people who exercised at a moderate level, I'll talk about that a little later, what that is, had a 40% reduction in breast cancer recurrence. And really a remarkable, noticeable, true reduction in cancer recurrence. And a more recent study in the clinical breast cancer in 2018, this is a meta-analysis. This is where the authors put together many studies that are similar to each other so they can get a larger number of patients, a larger number of people, and look at the results. And that's gives us a more accurate idea of the results, because the more people in a study, the more accurate. And this was comparing physically active versus sedentary people. And the studies had slight differences in their definition of physical activity. But again, we saw in this group of studies put together a 12 to 21% reduction in breast cancer. And as you see, 41% reduction in all-cause mortality just reflects how crucial exercise is to our overall health. Colon cancer, likewise, another meta-analysis showing that a high level of physical activity reduced the risk of colon cancer by 19%, pretty large. And this has a variety of reasons. It has an effect on how bile acids are metabolized in the body, and also exercise reduces the amount of time our food spends in our digestive system. And food that is digested and is in our intestine is felt to produce some toxins that may be carcinogenic to the intestine itself. So the faster that you can get food out of your intestine, the better for you, and exercise does help that. Prostate cancer, which obviously we have many cases of prostate cancer in this country per year. Another study, men in Sweden, in this case, doing that 30-minute vigorous walk. And they had a 39% reduction in mortality from prostate cancer. And again, we also see that large reduction in all-cause mortality. Same with esophageal cancer, another meta-analysis, greater than 20% reduction. So how do we get started? I see a lot of patients in various ages, various states of health, and various stages of fitness, and give a lot of advice and recommendations to start. And the real magic of exercise is that any level of exercise is better than any lower level of exercise. So we will have a goal of that 150 minutes a week, but anytime you start physical movement, rather than being sedentary, you start to get the physical results. And any person, any age, any level of fitness can increase their fitness and continue to do so over time. So no fancy equipment is needed. If you have not exercised and you have some pre-existing conditions, you may need to get some medical clearance before you start having a goal of moderate exercise. Likewise, some of the side effects of chemotherapy, such as peripheral neuropathy, there will be some precautions of activities you should or shouldn't do. So you want to seek advice from your doctors, myself, people who are experienced in guiding you in how to begin your exercise program. And in the pandemic, we can't really go to gyms. So this is my little home gym and my little mouse chaser, how to be in the picture. So you want to do a combination of weights, and we've got a few light weights. You want to do some resistance with bands. Also, the different balls are good for back and core muscle exercises. And this is my laptop, actually. And so nowadays, there is really a plethora of exercise videos that you can go to until we decide we can go back to the gym. Or if you prefer to exercise at home, you can do a lot yourself. Usually I recommend people begin with walking, and we all have pedometers attached to our bodies now in our phones or our watches, or you can get a little belt pedometer. I generally recommend to my patients, just take 2 weeks and count your steps. Don't make any change in what you're doing. And then set a goal to increase that number by 10% every week or so. And this will gradually get you walking up without you noticing a big impact in how much time it takes. The goal of 10,000 steps per day is often given as the fitness goal. This is pretty time consuming. It is pretty weather dependent. So for that goal, a lot of people will do better with a home treadmill or at the gym if they're going, or an exercise bicycle, an elliptical, to get that cardio part of the exercise going. Weight training is the other important part, and we recommend this 2 to 3 times a week. You do a variety of exercises for your arms and legs, maybe about 8 different ones total. You do what are called repetitions, 10 times, that's a set. You take a rest, do it again. And the real key is to gradually increase your resistance, gradually increase the weights that you're using. And that's how you will increase your strength and get the benefit of the exercise from you. And weight training will help increase your strength and muscle mass. In addition to the anti-inflammatory effects, it will reverse often a lot of the muscle wasting we see due to illness. Many people who are chronically ill or have been receiving treatments such as chemotherapy have become sedentary, their nutrition has declined, will experience muscle wasting. And you can rebuild your muscle with weight training. And again, at any age, you can increase your muscle strength. So the optimum dose of exercise is medicine, and you want a good dose of it, is, as Melinda said, about 150 minutes a week of what's called moderate exercise. And an easy way to gauge moderate exercise is that you're lightly sweating. You can talk, you're not out running at a full pace where you're breathing so heavily you can't talk, but you are doing enough that you'll start to sweat after a while. So that walk in the park is a great thing to do, enjoyable, it gets you moving, but to get that real exercise dose, you want to up it a little bit, maybe walk up hills a little bit more, increase the weights that you're using. And as you heard, you can divide it into intervals almost any way that you want to get that 150 minutes. So the next program was mentioned. Just to wrap up, I want to say at Greenwich Hospital, we offer an exercise program to all our breast cancer patients, and it's now meeting twice a week, hopefully one day we'll go back to the 3 times a week that we did. And this is a combination of aerobic exercise, strengthening, stretching, balance, and yoga. You're supervised by our staff, and these are exercise physiologists. They have master's degrees in exercise. They work with our cardiac rehab patients who have heart disease, pulmonary rehab patients with lung disease. So they are very used to working with people who have illnesses and who have limitations in what they can do at the beginning. And we encourage you and would like people to start it during the year that they've completed treatment. If you're receiving some other treatment at the same time, generally after that's over, sometimes we can do it. And this is free of charge, 3 months, free exercise program. So please come and join us. This is the contact number that you can use. And that was my talk.
Wonderful. Thank you, Dr. Freedman. I think the most important message is, as you said, something is better than nothing. So don't be intimidated by a 2.5 hours per week of exercise, but anything is better than nothing. So Dr. Boyd, do you want to try to pull up your slides, or would you like me to do it?
I emailed you my slides, so maybe you could.
Okay, sure. I'll do it.
And I'd like to, by the way, congratulate Melinda. I've watched 20 years of your program development, and it's been quite remarkable what you've achieved.
Oh.
So I want to compliment you on that. Now,
Well,
let me
thank you. Well, and I've enjoyed having so many of your patients referred to our studies. So thank you. Okay,
let me
now
see
I
if
have
I
to
can-
figure out how to get the, so you only see one version of it, right? Is that good?
I
Hold
only
on.
see this. Does everybody see the actual presentation?
We're seeing your whole laptop.
Okay, I'm going to, good?
Yes.
Okay, good.
Okay, great.
All right. So I'm going to kind of tie it up. As I said, speaking about nutrition and cancer in this time is a little bit like reviewing the history of World War II in 10 minutes. Given the complexity of this, let me make sure I have.
And you have to tell me next slide.
Oh yeah, next. Okay. And of course, the puzzle of nutrition and how it fits into lifestyle and cancer is the complexity of what we've learned over the last really 50 years. Next slide. And of course, one of the common quotes is Hippocrates saying, "Let food be thy medicine, and medicine be thy food." And many people in the world of complementary or functional medicine have used this as an argument about medicine as food as a way to treat cancer. And I think we need to take a step back and recognize that while it is incredibly important, it isn't an alternative therapy for cancer. And I think that's one of the things I find in many of my patients who come to me, refuse conventional treatment and simply want to use diet as an alternative. And this is the battle I fight every day with many of my patients. Next. And of course, what the problem is this is of all of the things we've talked about, this is filled with, the enormous plethora of information on the internet, in books, many of which promote the idea that you can treat your cancer or prevent cancer with food. Very simplistic ideas and often not really science-based. Next. And in fact, it's worth knowing what Hippocrates also said, at least he's quoted as saying, I didn't hear him say this. In fact, there are two things, science and opinion. The former begets knowledge, the latter ignorance. And I think we have to recognize that's probably even more important. Next. And so we do know that the majority of patients seek dietary advice. They're highly motivated. They want to improve both their quality of life, and more importantly, they think of nutrition and what they do, particularly exercise, which we've learned, as a way to improve outcome. They're very vulnerable, so they'll do whatever it takes. And unfortunately, a very high percentage will use dietary supplements and nutraceuticals in order to achieve those goals. Next. Now, this is a very fascinating study. This is a fascinating paper that was written in ESMO in 2018, worth knowing the importance of a practicing oncologist interdisciplinary position. They say medical oncologists, other healthcare professionals treating patients with cancer seem to neglect nutritional issues. Now, this is not for any other reason that they're overwhelmed, number one, and they're not trained in nutrition. And nutrition is a major issue for most patients. These are all quotes from that paper, and lack of guidance leads to doubtful self-management strategies. And most importantly, intriguingly, the European Cancer Patient Coalition published a cancer patient's nutritional bill of rights that was presented in the European Parliament in 2017. So this is now being seen politically as a very important issue that needs to be addressed for patients. Next. One of the earliest studies, just get rid of that. One of the earliest studies looking at the causes of cancer was the Dolan-Peto study from 1981. Two esteemed epidemiologists from Great Britain who came to the US and looked at what they thought were the potential cause of cancer. And they estimated that diet played a role between 1/3 and 2/3 of cancers. Go next. But we need to think more deeply about how we think about diet. Is it overall diet or individual nutrients and constituents, which is a very common misconception. The idea of reductionism, which has been the way we've looked at nutrition for the last 30 to 40 years, is reducing it to the ingredients. Is it meal size and frequency? And the very important concept that has been promoted by David Jacobs, who is an epidemiologist at the University of Minnesota, nutrient synergy. Foods are more than the combination of their individual nutrients. And lastly, the critical role of dietary pattern. And also diet interacts with obesity, BMI, physical activity, genetic differences, and also increasingly we're learning about the role of diet and the microbiome and how that can change human physiology. And lastly, the idea of non-food contaminants. Now, I want to present a very interesting idea, what Walter Willett next talks about, which are the 4 paradigms. And he's now talking about what he calls the 4th paradigm when he talks about understanding the evolution of the epidemiology of diet and nutrition and how we can understand causation. And the first paradigm from the early 70s and 80s was the idea of carcinogens in the food. And yes, they may play a role, we know, with processed meats and some other carcinogen contaminants, but overall, as he says, this has played a really limited role in cancer risk within the population. Next. And of course, as we start to look at different populations, the next very popular hypothesis was dietary fat. And this came out of studies when you look at different populations and fat intake, showing that high fat consuming populations have higher risk. And this was extremely popular and led to studies, an enormous number of studies at that period of time. Next. Now, this is an example of dietary fat in breast cancer, and you can reproduce this for prostate cancer and other malignancies like endometrial. That population-based consumption of dietary fat per capita correlates with risk, and you can see where the US is there. Japan and low-risk countries are down at the bottom. But when you then look at the data more nuanced in prospective studies, next, and the next one is from the Harvard Health Professional Study, Nurses Health Study, you see that there is really no association between high and low percent dietary fat and breast cancer risk within some nuances. Now, what that led to is the next paradigm, which became extremely popular and still remains a fundamental understanding for most people, is it must be the fruits and vegetables. And this became popular, led to the 5-a-day idea. We all recognize the critical value of plant-based foods, enormous explosion in phytonutrient research, and with that, an explosion in the use of nutraceuticals and supplements to mimic that. And lastly, chemotherapy trials, chemoprevention trials, that is, designed to take selective nutrients that were felt to be related to cancer to try to reduce risk. And next. This is Gladys Block, who actually published in the early 90s a case control study showing a strong relationship between low dietary fruits and vegetables and twice the risk of cancer. So it suggested that simply increasing consumption of fruits and vegetables will have a major impact. Next. But that's led, actually, interestingly, when you actually dissect the data about adding fruits and vegetables per se, you see it has a substantial relationship to cardiovascular risk, Nurses Health Study, Health Professional Study, but actually had much less of an effect on cancer risk than one might assume, simply adding fruits and vegetables. Next. And this led to a number of analyses from the European Perspective Investigation of Cancer Nutrition. And as Walter Willett, the head of nutrition at Harvard, said turmoil in the produce section when they analyzed the consumption of fruits and vegetables intake within the European population, this large European population. They found that there was only a 2 to 3% difference in risk between high and low populations, suggesting a broad effort to simply increase the consumption of fruits and vegetables will not have a major impact on cancer incidence. Next. Now, here's one way to think about it. If you take a Big Mac, look at the calories, and then you add to it next a salad that makes you feel virtuous, you've added calories, but you still have that same diet. And when we simply think about adding fruits and vegetables, you end up missing the bigger picture here. Next. And again, that must have been added, another Big Mac. Keep going, sorry. And the other part of this dilemma is people have reduced the plants and the nutraceuticals to their individual components, thinking let's add the nutrients to our diet as single supplements, creating the sense that we are taking the vegetables without the vegetables. Next. And then we came upon this concept of high dose micronutrients and cancer. Can we prevent cancer by adding micronutrients at higher doses? Because there is some evidence that certain foods, for instance, cruciferous vegetables or carotenoids, can lower the risk of some cancers. Next. And there was a suggestion beta-carotene can reduce cancer, particularly lung cancer. And this was a very popular hypothesis based on retrospective analysis. Next. But when they added beta-carotene as a supplement to try to prevent lung cancer, it actually raised lung cancer risk. This is what I call one of the most famous foundational studies that nobody has ever heard of, because most people have never heard of this study. In fact, Cancer Treatment Centers America sold beta-carotene on their website. And again, this is not the answer, taking high doses. Next. We found the same type of study in the SELECT trial that taking vitamin E or selenium may reduce, in theory, the risk of prostate cancer, and we got the reverse. High doses of vitamin E increased prostate cancer risk, selenium increased diabetic risk. And there's a fundamental point to all of this. Next. The doses are very high, and there's a thing called the U-shaped curve. When people exceed the levels of the median level that is necessary for good health, you actually at higher levels can increase risk rather than lower risk. And this has been shown for most of the nutrients we look at. Alpha tocopherol, the same thing has been shown for the next. We'll show you this, and this is vitamin D. And of course, this was the nutrient du jour. And interestingly, the VITAL study, which was a randomized trial of vitamin D and or fish oil, showed that vitamin D, 1,000 units of 1,000 units of D3, did not impact on the risk of cancer or heart disease. And you see here, there's actually a U-shaped curve for vitamin D. Next. And there's also a U-shaped curve for overall survival. And it turns out that the level at which it starts to go up was in the range that we used to consider normal. So the levels of vitamin D may play a role in survival. There's more and more data that vitamin D adequacy is necessary for cancer survival, but itself may not play as much of a role in cancer causation. But certainly adequacy is important for overall health. Next. Now, here's another very interesting study. This is a retrospective analysis from what's called a prospective study from DELCAP, from a very large trial for in early stage chemotherapy. And they looked at women's use of supplements and analyzed what was the effect on outcome. Not a randomized trial. This was simply a prospective analysis looking at what happened. And what was interesting was, in combination, the use of antioxidants appeared to increase risk of recurrence and to a lesser extent mortality. Second, B12, before and during chemotherapy, as a supplement, seemed to decrease progression-free survival and overall survival. So it seemed that B12, perhaps the strongest effect, twice the risk of mortality in those taking B12. Now, it should be noted that B12 has also been shown to be potentially a risk factor for lung cancer in both a randomized trial from Scandinavia and in a recent meta-analysis of a number of studies, of large prospective studies. So we take B12 at levels far beyond what most people realize, so that patients come to me taking 5,000 to 10,000 micrograms of B12, and that's the equivalent of 200 to 400,000% of your daily requirement. Now that's biologically irrational. That's a drug and not a supplement. And lastly, iron was associated with increased recurrence. Interestingly, multivitamins, and this has been repeated in several studies, was not associated with adverse survival outcome or better outcome. So it's really a clue that taking dietary supplements, particularly at high levels, may be a risk. I already showed you the chemo prevention studies, and those were largely antioxidants, vitamin E and beta-carotene. And there's an argument that actually tumors don't like oxidative stress. And when you add antioxidants, you actually may promote tumor progression. There's good evidence for that. Next. Now, this is a study that was published in 2013 from the Women's Health Initiative looking at breast cancers, women with postmenopause with invasive breast cancer. And what was interesting with this is that those women who actually took a multivitamin, not in high doses, had a 30% lower breast cancer mortality. This was highly robust. Rowan Chablowski and I talked to you. They'd made multiple adjustments. It isn't clear that it's necessary, but it argues that it's simply a multivitamin is not harmful. I don't argue for it, but for those where diet is uncertain, it is important. Next. On the other hand, one of the most common supplements that women take and are concerned about was the myth that soy is an enhancer of tumor progression. From older information about the genistein, the similarity to estradiol. Next. But in the after breast cancer pooling project and a number of other individual studies, there appeared to be no association with risk of recurrence and soy intake as a food rather than as a supplement. So one might be reassured that when you take soy as part of your diet, it's not a risk factor. I mean, I have women coming to me and they can't take a little soy sauce because they're worried it will raise their cancer risk. And those are the myths that are out there, which, abound because of this information. Next. Now, what do traditional early human societies share? Next. As has been the case with all of our discussions, energy balance. They exert enormous amount of energy with exercise. They, as I said, they hunt for their food rather than go drive to the store or order it online. And so physical activity was central to all of human history. And of course, they were balanced with traditional whole foods that they grew or caught. Next. And so this is the fourth paradigm that Walter Willett says really is probably the central paradigm. It's not the fat, it's not just adding fruits and vegetables, it's the central role of obesity, energy balance, which we've heard already about. And BMI increases cancer risk and mortality from multiple studies. What's also really interesting is early childhood growth, which is part of our modern life, causes increasing height, and there's correlations between height and cancer risk. You can't change your height, but you can certainly change your adult weight. Other models looking at this include caloric restriction, working through the idea of reducing insulin IGF, as well as reducing estrogen, and some of the diets we talked about. Now very popular intermittent fasting, daily caloric restriction, et cetera. Macronutrient restriction is at low fat. Well, we've already talked about that, but low carbohydrate, particularly concentrated carbohydrates, look to be very important. And we now know that many tumors depend through chemo, what we call cancer reprogramming. They use high levels of glucose. Next. And this is just an example of the relationship between height, weight, and breast cancer risk over time. Next. And again, this is the CPS2 study. This reproduces what we've already heard, the relationship between BMI and cancer risk in multiple cancers. And again, as Dr. Melinda Irwin said, uterine is among the highest when it comes to the relationship between obesity and risk. Next. But we mustn't forget that there's this other concept, which is metabolic, which is what we call metabolically obese normal weight. There are some individuals, as they lose muscle mass, may not have the appearance of increased obesity, but share the same metabolic effects of those patients who are with high BMIs. This happens with the elderly. It happens with cancer patients as they progress. And so we must be aware of not missing patients who have this, who are, they might have a little pot, they have lean muscle, they have low muscle mass, et cetera. Next. And again, the issue of carbohydrate, which was raised before, low carb diets may potentially reduce tumor promotion, improve survival. There's observations, but they're still limited. And much of the focus has been looking at calorie dense and caloric and high carb diets that may enhance insulin IGF pathways using approaches like caloric restriction, the ketogenic diet, which one must be cautious with, low carb diets, and pharmacologic approaches like metformin. And patients are doing this every day. They come to me doing this. I have to advise them about the pros and cons. Extended overnight fasting, which Ruth Patterson and others have shown may affect some of the metabolic features that link to cancer. Intermittent fasting, pre-chemotherapy fasting. Many patients want to go on a fast before they get chemotherapy based on data from Walter Longo, but all of this is experimental and has to be followed with a nutritionist and or dietitian rather than doing it on your own. Extremely low carb diets and ketogenic diets, again, may have adverse risks. And people are now using alkaline diets and insulin potentiation therapy. These are the things that people come to me with. I have to educate them about cautions. Next. But here's something very interesting. This was data looking at multiple studies on the relationship between animal and plant-based low-carb diets. And it shows intriguingly that mortality, when you decrease carbohydrates, you increase fat. And generally what happens is you can either increase fat in the Paleolithic or ketogenic approach, which often substitutes animal-based products, or vegetable-based low carbohydrate diets. And it shows you that there's actually an increased mortality when it's focused on animal-based rather than plant-based. So plant-based diets in this concept of low concentrated carbs may be a much healthier approach to keep those down. Next. And again, dietary patterns are probably more central to this. The Western meat and potatoes increases breast, colorectal cancer, where Western diets, and this is an additional important concept, ultra-processed foods. Those foods at the center of the supermarket, and there's more interest now in looking at ultra-processed foods as having a relationship to metabolic dysfunction as opposed to the whole food approach. And prudent plant-based diets, as I outlined here, particularly of fruits and vegetables in a context of this dietary pattern, and high fiber. This fiber often mediates many of the benefits metabolically within the colon, and also, as we talked about before, and may also alter beneficially the microbiome. They're associated with reduced recurrence, improved survival, and maybe in benefit in patients with early advanced cancers. And this prudent type diet is associated with lower weight, lower glycemic index, and reduces C-peptide or insulin resistance. Next. And this is an example of adherence to the Mediterranean diet and breast cancer risk, showing that the Mediterranean diet, as an example of a healthy dietary pattern, is associated with reduction in risk. And if you look at where whole grains are, they're particularly associated with reduced recurrence, whereas meat works in the other direction. So the individual components, Mediterranean diet is a good example of a healthy dietary pattern. Next. And this just reinforces what we've heard before. When you combine physical activity and caloric restriction together, you maximally reduce insulin and many of the metabolic factors that are linked to adverse outcome. I will say it's very important to realize that these are shared between cancer, cardiovascular disease, diabetes, and many patients who develop cancer become at risk for other diseases like heart disease. And that may be a bigger issue for their outcome, like prostate cancer patients who go on to ADT are at a higher risk for dying of a heart attack than often they are from their prostate cancer. So we need to look at this as a central mediator of overall long-term health and outcome. Next. And so as Hippocrates says, walking is the best medicine. And lastly, dietary goals, plant-based diet, prudent, reduces weight, improves metabolic status, disease risk, and daily function. It's not individual foods. Food synergy is critical to understand. Limit calorie-dense foods, the ultra-processed foods that have an adverse impact on metabolism, limit red meat and high-fat dairy, limit calorie-dense refined carbohydrates. I agree 100% with what we discussed before. Sugar, fructose-based corn syrup, high-calorie soda, fruit juices all have a negative impact on weight gain, even in childhood and adulthood. And the whites, and emphasize whole grains, high in fiber, nutrients, Increase the diversity of plant-based foods. Dietary soy is not a risk. Limit alcohol. It clearly has been consistently associated, modestly, but for real, 15% increase in breast cancer risk, as well as other cancers. But obviously one has to balance the cardiovascular benefit, which may be modest, with cancer risk. And avoid high-dose supplements. Always remember the U-shaped curve. Adequate vitamin D is important. Daily multivitamin, maybe if you don't have adequate foods, but I would say get your nutrients from your food and avoid the use of very complex phytonutrient intake as a pill rather than as the food. Last, maintain healthy body composition, available evidence. Medical oncologists should incorporate dietary habits and lifestyle as a prominent component of breast cancer adjuvant treatment. I know that Melinda talks about exercise as adjuvant therapy for cancer, and I really want to praise her for all her work. Thank you.
That was great. If I may just make a quick comment, and then we'll look at our chat screen to answer questions. But you know, the way you laid out the dietary findings over the years, you know, patients in the population can be get dizzy from, it seems like ping-ponging back and forth. But I think it's important to note that in the 80s, when a lot of the research came out about dietary fat causing an increased risk, what happened was the food industry responded by adding a bunch of sugar to the foods. Reducing dietary fat, but to make it palatable, they added sugar. And that then caused a tsunami of high sugar intake diets. And so the epidemiologists and the dietitians and the nutritionists weren't saying add sugar. They were saying just reduce fat. So I think that's why, from my vantage point, it's not the personal choices we're making. It's that a lot of it's our environment, our built environment, the technological advances, the changes in the food industry that make it really challenging for people to maintain a healthy weight as we age. And so, you know, arming us all with this evidence is good to be, you know, knowing what is right now the recommended guidelines. So I appreciate both your talks, and I think we should look at the chat box. So I just like to quickly thank Heather Studwell, who organized this event, as well as Renee Gaudette. Heather is the Oncology Survivorship Coordinator at Greenwich, and Renee Gaudette is Head of Communications for Yale Cancer Center. And the slides will be available on the Greenwich website, and we encourage you to look there. You can also call the Greenwich Care Center for information, and also view the yalecancercenter.org website. So you can get the slides there. There's a question for you, Dr. Freedman. Do you recommend exercise during chemotherapy or wait until after chemo?
So as I put in my answer, yes, I do, although it's an individual decision and judgment. Exercise during chemotherapy can help reduce some of the side effects. It definitely helps reduce fatigue, and fatigue is tiredness that's not relieved by resting, but exercise definitely reduces fatigue. Exercise will help you reduce that risk of loss of muscle mass from being sedentary, and also will give you, you know, a general overall well-being. People with peripheral neuropathy, for example, should, I don't believe, be doing a lot of impact or even walking on hard surfaces. So I'll generally recommend they are using something like bicycle or elliptical if they want to do that kind of cardio, as opposed to slapping their feet on the ground for long distances. They may particularly benefit from things such as yoga or balance exercises also. So we try to put together really an individual package of exercise. Certainly, if you were an exerciser before, you can continue pretty much as you are able to. The big thing is people who were exercisers before who have really dropped down during chemotherapy or after surgery need to start slower, not just try to jump right back to where they were. So those are all things that we can guide you in to individualize a program.
Great advice. And then Dr. Boyd, what is the role of antioxidants in our diets and cancer prevention? Is it possible to have too many antioxidants? And I think you did answer that question, but it's such an important message. So if you want to briefly mention again about antioxidants and supplements.
Yeah, I think, we mistake the idea of a healthy diet with antioxidants, which is extremely important as a part of your diet, with the use of supplemental antioxidants, which are very often in extremely high doses relative to what's in the diet. And cancers have the same U-shaped curve. Causation of cancer may rely on adequate controls against oxidative stress, but tumors themselves depend on preventing oxidative stress. And so they upregulate their own antioxidant mechanisms. And when we give high-dose antioxidants, and this has been shown in studies, it actually can enhance tumor growth and tumor metastasis. There have been 2 studies, a very common supplement, N-acetylcysteine, which most people think, oh, it's benign. It's a precursor to glutathione. And when people have taken them, when they've done these studies, it actually enhances tumor growth. So we have to be careful to assume that supplements are safe when they're over the counter.
And there's research showing too that it can interact negatively with your adjuvant treatments, with your chemotherapy and your endocrine therapy. And so best to definitely consult with your oncologist. And, there are dietitians now who are specialized in oncology nutrition who are experts in this place. And we have many of them certified here at Greenwich and in the Smilow care centers. And there's a database you can go to that they will look at what supplements that you're taking and if they're contraindicated based on your treatment type. So it's a really important subject, and to be careful and to share with your treating physician.
One I might mention, Melinda, is the very common use of fish oil. And there was an intriguing series of studies from the Netherlands that when you take high levels of fish oil during platinum-based chemotherapy, it actually induces resistance to chemotherapy. And so there's been this assumption that many of these foods that we get over the counter and everybody takes are really safe, and they may not be. We really need to be careful.
And unfortunately, it's unregulated by the FDA.
Right.
So none of these supplements, the over-the-counter supplements, are regulated. So you really have to be a smart consumer and discuss this with your clinicians. So I learned a lot. I enjoyed this. Thank you so much, Dr. Boyd and Dr. Friedman. And we are here. You can get our emails from good old internet or reach out to on the website for Greenwich Hospital and the Yale Cancer Center, and we can be happy to answer any additional questions at that time. But thank you all so much for tuning in.
Thank you, Melinda, for leading this and for your work.
Have a good night, everyone.
Good night.